you very much, and thanks very much, and welcome back to our next session. And we just have a little technical issues, so I'm just catching up. So it gives me great pleasure to introduce our next plenary session, which is the development in the hospital payment system for the National Health Service in England, which is presented by Mr. Martin Campbell. Martin joins us today all the way from the UK, where he's held a number of senior finance roles in the NHS England and the Department of Health. After starting out as an analyst, Martin led the Department of Health team that coordinated the spending review bids for NHS adult social care, and he was also responsible for reviewing the primary care trust allocation formula, including the market forces factor. For the last few years, Martin has worked on the national tariff, first as head of the payment by results development team in the Department of Health, responsible for the design of the tariff, including the introduction of the best practice tariffs, which is something we at IPRA have looked at very closely, and then as head of pricing in the NHS England, leading its national tariff responsibilities and working alongside NHS improvements. So thanks very much, Martin, for joining us, and we look forward to your presentation.
Thanks, James. That's really nice, and thanks for the invite to come speak at this conference. It's really great to come and share this with you. So, as James said, I work for the National Health Service in England, and I've been working in the area of hospital payments for probably over 10 years. And I'm going to talk to you today about recent developments in the hospital payment system for the NHS in England. I feel like a slight fraud actually coming to an activity-based funding conference, and I'm going to talk to you about how we're sort of slightly moving away from that approach in England, but hopefully I'll be able to set out the reasons for doing that, and particularly in the context of the health service in England. So I'm going to give you a bit of a brief of how the funding flows operate for the NHS in England, with a bit of a history of activity-based funding in England since the early 2000s, and then briefly talk about the emergency payment arrangements that we introduced during the pandemic, which we're just coming out of. That's the emergency payment arrangements rather than the pandemic, and also then describe the new payment model that we're introducing in England. And finally, I'll talk a bit about the potential future developments that we're looking at for the payment system in England. So first of all, a bit of a reminder of what the structure of the National Health Service looks like in England, and as usual, we like to change this on a regular basis. And there's an act just been passed by Parliament last week, which will change this slightly, and I'll talk about that a bit more. But generally, the approach is that the Department of Health and Social Care passes on the funding to NHS England, who I work for, and NHS England's responsibility is to allocate the money to the health service and set out the rules and the priorities for that funding. And the payment system, so that covers the rules and the prices for the arrangements between what we call commissioners and hospitals or providers. So when we talk about commissioners, they are sort of at the moment the clinical commissioning groups. We've got about 100 clinical commissioning groups who are responsible for the commissioning the healthcare for their population. So they design, find out what's required for their population, and agree with the hospitals the level of care and the amount of care that's provided for their population across both acute mental health community and ambulance services. And we also have a number of regional commissioners who commission more specialized activity where it's not appropriate to do so, or at a local level. So as I said, there's a new health and care bill which has been passed last week, and clinical commissioning groups will be replaced by integrated care boards, and there'll be 42 of those. But the same sort of scope in terms of the payment system will remain. So a bit of a history of activity-based funding in England. So it was first introduced as part of the Blair government's reforms of the NHS in the early 2000s. So it was a time of significant increase in funding for the NHS, and also the introduction of patient choice, where patients could choose providers. So they wanted a payment system where money could follow the patient. And also at the time we had significant waiting lists, and there was a policy to reduce waiting lists and waiting times. So we wanted an incentive on hospitals to reduce waiting lists, and also increase the plurality of providers, so having a payment system that worked for both public NHS hospitals and private independent sector providers. So we introduced what was called payment by results in 2003-4 for a small number of HRGs, elective HRGs, and fairly quickly expanded that to cover the majority of acute activity, and that stayed pretty much the same until about 14-15. We did introduce some best practice tariffs over that time, but in 2014-15, as part of the Andrew Lansley reforms, the payment system was put on a legislative footing and changed its name. So we do a change in names in the health service in England. So we could change the name to the National Tariff Payment System, which was basically exactly the same structure, but replacing what was called payment by results. And it also meant that responsibility for the payment system changed from the Department of Health to two new organisations, NHS England and the NHS Improvement, and we split responsibility for the payment system between those two organisations, with NHS England generally responsible for the design of the payment system, and NHS Improvement responsible for the calculation of the prices and collecting the costing data. And we both had to agree. And if anybody's looking at redesigning their sort of responsibility for the payment system, that's probably not a model I would recommend. But then in 2019, the NHS long-term plan, which set out this future strategic direction for the health service in England, committed to some payment system reform, moving away from activity-based payments to a population-based payment, starting with what's called a blended payment model. And we started to introduce that in 1920 for urgent emergency care. And then we obviously had the emergency payment arrangements as part of the COVID response. And then this year, we're just moving to a form of blended payment that we're calling aligned payment incentives. And then, I said previously, a new act has just been passed last week, which again changes the name of the activity-based funding arrangements to called the NHS Payment Scheme, and introduces some slight change in the rules and flexibilities in what we can do with the payment system. And I'll talk about that a bit more later. So just what's within the scope of the national tariff and national payment system. So it's about £80 billion in total, split sort of almost 50-50 between where we have national prices for the majority of acute activity, the usual stuff, elective, non-elective, outpatients, maternity, visits to accident and emergency centres, but also we have prices for chemotherapy, radiotherapy, diagnostics, stuff like that. And then there's also some activity where we have rules for the payment, but don't have national prices, such as mental health, community and ambulance services. So as I said, so the NHS payment system has been based on had a legislative footing since 2014, and setting out exactly how we can set the prices and rules for payment for hospitals. There's a requirement on us to consult hospitals and commissioners before we publish the payment system, and hospitals and commissioners can object if they don't like the method that we're using to set the prices. And if the level of objections reaches a certain threshold, which is currently 66%, then we can't then publish the payment system unless we've either reconsulted or referred the objections to the Competition and Markets Authority, who can then make a ruling whether we should continue to publish or publish with certain changes. But also there's quite a significant amount of flexibility currently with between hospitals and commissioners, and if they both agree and it's in the best interests of patients, that they can vary away from the national prices and rules to something locally, and increasingly numbers have done so. And also hospitals in England can apply to receive a higher price, a local modification to national prices in specific circumstances, such as specific rurality, where they're not able to provide the service for the national price. But at the moment, only one modification has been approved. And as said, the Health and Care Bill does introduce some changes to these arrangements. So now getting into a bit of the change in the payment system that we have for the last few years. So for a number of reasons, really, even before the pandemic, a significant number of hospitals and commissioners had got together and agreed to move away from activity-based funding for acute care to a more of a fixed and more bundled payment model, such as by the time of the start of the pandemic 2021, over half of the health systems in the country were planning to move away from the national payment rules to something simpler, which was either called block payments or aligned incentive contracts. And that was for a number of reasons, really. We'd had a number of years of very tight financial settlements for the NHS following the financial crash, with prices not really being cost reflective. So this had led to quite large financial deficits in either the providers or commissioners across the country, and also the general payment system we had, which was sort of setting hospitals and commissioners against each other in some parts of the country. So where finance was quite tight, if a hospital was really cracking through lots of activity, that could end up with the commissioner being in deficit. And if the commissioner was being very tight with their allocations, then the hospital could end up being a significant deficit. So we ended up with this almost arms war of hospitals really putting in lots of effort to improve their coding, and some commissioners employing armies of people to check the invoices on a monthly basis that commissioners were sending them to make sure they were being billed appropriately. So that didn't really support the working together of providers and commissioners that we're looking for to make the best use of the resources available. So that's why a lot of hospitals and commissioners decided to move away to a more of a fixed or a bundled payment to give them that budgetary certainty, given the limited money available, and led to a focus they felt on so they could manage costs rather than maximizing income through a payment by activity approach. So that's the bit of the background to where we're ending up with. And then as part of that, the NHS long-term plan in 2019, as well as setting out the introduction of integrated care systems, where hospitals and commissioners were getting together to plan the care for their population. It also set out some reforms to the payment system, with specifically a moving away from activity-based payment to what was called a population-based payment system, with a move to a blended payment model, beginning with emergency and urgent care. And that was to support the move to more preventative and anticipatory care models and reduce some of the transaction costs that we'd seen between providers and commissioners. So what do we mean when we talk about a blended payment model? So essentially, it's a mix of a fixed payment covering all the scope of all the services between a commissioner and the hospital, with at least one of a variable payment. So where the activity levels differ from plan, the actual payment can be varied up or down. It could also be having a risk sharing element between providers and commissioners. So either the finances don't quite go as planned, or activity is significantly different from planned, and rather than having a variable payment, they just agree that actually, if that happens, we'll get together and decide exactly what we're going to do to react to that. And also, you could have a quality and incentive element as part of the payment model, and that's what we've been looking to implement, and that's designed to address some of the issues with the current payment system, including the fragmented approach that we've got, making it quite challenging to integrate and reconfigure care models across the system. So we've come from a position with essentially activity-based funding in acute care and block payments in mental health and community care, and actually given the policy of moving activity out of the acute setting into the community setting where possible, those payment models just weren't aligning with the direction of policy. And also trying to have a set up a payment system which supported collaborative behaviours between commissioners and providers, rather than setting providers and commissioners against each other, which was happening in some circumstances, some parts of the country. So we've our initial movement away from the payment by activity model in 1920. We started this for urgent and emergency care, where we introduced rules that hospitals and commissioners need to agree a fixed payment based on a planned level of activity for non-elective and accident and emergency attendances. Where that activity was different from plan, then the actual payment could vary by 20% up and down for that the value of the activity that's different from plan. And this was designed to try and bring hospitals in to help with managing demand for emergency care, and a payment model that just rewarded hospitals for doing more activity wasn't quite aligned with that direction of policy. And then in 2021, we had planned to expand that approach to cover maternity and outpatient settings, but slightly different. So rather than having a variable payment, a set variable payment for that, we just had a fixed payment, but with an option that hospitals and commissioners could agree to risk share where activity ended up significantly different from plan. And the rationale for expanding into those two services was generally that those that felt that demand for maternity care should be sort of fairly predictable, and also a policy that we felt we had a lot of outpatient follow-ups that probably weren't needed. So a payment model that rewarded hospitals for every time somebody came in as a follow-up, again, wasn't quite aligned with the policy approach. But actually, we didn't end up implementing those arrangements because of the pandemic, and we moved to a completely different payment model. So during the start of the pandemic, so the normal hospital payment model was suspended, and we moved to a very simple model with hospitals given a block payment based on the previous year's level of income, and that block payment was then topped up in year for any additional COVID specific costs based on submissions by the hospital to ourselves. So essentially, hospitals were being reimbursed for whatever the costs of delivering services, both COVID and non-COVID. So very sort of generous payment system for hospitals for those two years. And as we sort of came out the first wave of the pandemic to try and support a return to historical levels of elective activity and trying to reduce the significant backlog that that had built up for elective activity, we also introduced an incentive scheme so that hospitals could earn additional money if they returned elective activity back to 1920 levels. But we introduced that just as the time that the sort of second wave came in, which is a significant restriction in the amount of activity that was available for elective activity. So coming back to the blended payment model, so for 2022-23, we have implemented a form of blended payment model that we've called aligned payment and incentive model, which is essentially a fixed payment for almost all services covering acute, mental health, community and ambulance services, with a variable payment for elective activity. So as I said, a significant backlog had built up for elective activity. So currently we've got around 6.2 million people on the waiting list for elective activity. So that's around 11% of the population of England, with around 300,000 of those have been waiting more than a year for treatment. So to support that backlog recovery and to support the terms of the additional funding we'd got for that from the Treasury, we have introduced a funding system where funding for both hospitals and commissioners is dependent on getting back to historic levels of elective activity. So there is access to some additional funding, but dependent on delivering certain levels of activity. And the fixed payment, so what we're asking hospitals and commissioners to do is to agree a fixed payment looking at forward-looking levels of activity and costs. But for 22-23, they've done that on a fairly simple basis by sort of by the starting point rolling forward the previous year's level of fixed payments, so the amount of money they were getting during the pandemic, excluding COVID costs as the starting point for that. So this is very much a transitional year for 22-23, moving from those emergency payment models to a blended, making the first steps towards that blended payment model. So for 22-23, so as I said, the fixed payment covers almost all services. We do have some exclusions, so things like some high cost drugs and some innovative products will still be paid for on an activity basis or a pass through basis. We have this variable payment for elective activity where activity above or below plan is either paid for at 75% of the value, or the commissioner takes back 75% of the value of that if the activity is below plan, and that's to try and reflect the marginal costs of doing that activity, such as the staff and the fully variable elements. And we have also maintained the quality incentives that we've got, pay for performance incentives that we've currently got in the payment system. So they're called CQIN, which stands for the Commissioning for Quality and Innovation, and also best practice tariffs, which I'll mention a bit more in a minute. So I mentioned earlier the Health and Care Act. So this is just passed through Parliament last week, and so this abolishes the clinical commissioning groups and establishes integrated care boards. And so that's quite an important change for a number of reasons, rather than just being a name change and a number change. So it really, NHS providers, NHS hospitals will be formal partners of integrated care boards, and means they'll have a representative on the board. And also it means that they'll have a collective duty between hospitals and the ICBs not to spend more than their fair share of NHS resources, which in practice means the objective to set is to report a net financial position of at least break even. So previously a hospital could through its through increased inactivity could really shore up their own financial position but leave the commissioner in deficit, or the other way around. But now they're they're baked into this together, so both the financial position of both the hospital and the commissioner is part of their duty. And the Act also makes some reforms to the payment system. So as part of a wider removal of the competition elements from the 2012 Act, so it removes the role of the Competition and Markets Authority in the payment system, which was, so any rejection of the payment system could be referred to the CMA, so that's been removed. We've also removed the requirement, which was in the current payment system, to set at least some nationally mandated tariff prices, as we potentially move to more of a rules-based payment system rather than an episodic price-based system. Also introduces some various flexibility that we felt we needed, such as setting prices on a formula basis rather than an absolute value if we wanted to set a payment system over a number of years, and also set an ability to set differential prices or differential rules between the ownership status of certain hospitals, so between NHS and independent sector providers. It does still retain the requirement to consult and the ability of providers and commissioners to object to the tariff. And as I said, we do like a change in the name, and the change in the name from the national tariff to the NHS payment scheme. So 4 areas I'm going to briefly talk about in the future development of the payment system that we're looking at. One is the use of benchmarking products to support setting of the fixed payment, which is a really key part of the blended payment model, making sure we're getting that fixed payment correct. The development of currencies for non-acute services to support the payment model, to recognizing that we will need to continue some form of volume-based payments for elective activity for the next few years, given the level of backlog. So exactly how are we going to do that, and finally a review of the quality incentives we've got within the current payment model. So on the benchmarking products that we're developing to support the fixed payment, so we've come quite late to collecting patient level costs from all hospitals in the NHS. We've only recently mandated it for acute hospitals, and this is the first year that we've collected patient level costs from all mental health hospitals, and we're planning to roll that out to community and mental health hospitals over the next couple of years. So what we're planning to do is to use this much richer costing information that we've got to produce some benchmarking products to enable providers and commissioners to try and set that fixed payment based on a benchmark level with peers, and that hopefully are moving towards a level of efficient costs rather than just rolling over the previous year's fixed payment with adjustments for inflation and efficiency, which is a significant risk in the new payment system. So as well as sort of benchmarking information, looking at detailed information on hospital cost structures, we're also looking at some benchmarking information for subpopulation groups, and also for benchmarking by disease categories, looking at across the whole patient pathway. So as well as individual provider sectors, looking at the sort of costs across both acute, community, mental health, primary care, where we can get that information, and also producing some pathway-based costs based on clinical best practice. So we've just introduced that for some very high volume, low complexity procedures initially, but looking to roll that out across a range of medical conditions as well. So I think this for us is the key bit of our sort of future development of the blended payment model, how we can support that move away from very simple block contracts rolling over from year to year to something that's informed based on a sort of cost benchmarks, and is making the best use of the resources available to the health system. So on non-acute payments, so where we're for acute care, we're coming from a position where we've had payment by activities since the early 2000s. For mental health, community and ambulance providers, they've all remained virtually all on pretty simple block contracts, which have rolled over from year to year, and we've had very limited success so far in introducing any more sophisticated payment model for non-acute, and that's partly because of a lack of the data that could underpin that those payment models. So we just haven't got the same amount of detailed activity and cost data for non-acute services that we have for acute, and we've really struggled to get a clinical buy-in to some of our attempts to design currency models for non-acute services. So this is a real risk that commissioners and non-acute hospitals won't introduce the sort of principles of the blended payment that we're trying to introduce, and we'll just continue to roll over budgets from year to year due to lack of data and for sort of level of risk, I suppose. So developing the currencies for non-acute services is going to be a key part of that. And for adult and older people mental health currencies, so previously we'd made an
just 5 minutes to go.
Okay, thank you. That's great. So we will we started off by trying to design some currencies for mental health services based on care clusters, which were a set of wider determinants of a need for mental health services, and we really struggled to get widespread clinical buy-in for those currencies. Some hospitals really took them on and started using them, and some just didn't use them at all. So we're looking to design a new set of currencies for mental health services based on sort of broad diagnosis with a reflection of complexity, and these are being developed at the moment with clinically led groups. And we're hoping to sort of use these as the building blocks for both the cost and activity data that we'll collect. Similarly for community in the area of community services, so out of hospital services. So we're developing currencies in 5 areas: children and young people, long-term conditions, single episodes of care, frailty, and last year of life. Again, much better data on community and mental health couple of years to both base those benchmarking products that we're using and then use as the basis for the blended payment models for mental health and community services. So just finally on the quality incentives within the payment system. So at the moment we have two quality incentive or pay for performance schemes within the payment system. We have Sequin, or Commissioner for Quality and Innovation, which is worth up to 1.25% of the contract value for hospitals, and this is these are quite micro quality incentives that providers can receive, and actually it's not a very popular incentive within by hospitals. Hospitals see this as what should be part of their core funding, and they quite resent having to what they see as earning back some of their core funding for achieving some of these incentives. So again, a lot of hospitals and commissioners are sort of ignoring the financial elements of these incentives and just passing the payment directly to hospitals. We've also got some best practice tariffs, which we've been using for a number of years with various levels of success and various different models between differential payments based on achieving best practice or not, and some year of care payments for specific conditions, and also rewarding or incentivizing hospitals for submitting more detailed information to clinical databases or clinical audits, such as, for example, the best practice tariff for fragility hip fracture, which hospitals can receive additional payment for prompt surgery and the involvement of geriatric medicine. So we really need to, we're going to review the quality incentives that we've got within the payment system, and particularly best practice tariffs it's an episodic based payment system linked to the HRG prices, which doesn't really work alongside the move to a blended payment model. So we're thinking how we can retain some of the benefits of the best practice tariff model within that blended payment model. And also thinking a bit wider around the role of quality incentives within the payment system. So whether we need a slightly wider take on quality incentives within the payment system in England. So that's the slides I was going to go through. So thanks for listening. And so just in summary, in England, so we've started to move away from wholly activity-based payment model for acute service to a more bundled payment that we're calling blended payment. I mean, at the moment, that's a relatively simple model that we've taken as part of the transition away from the emergency payment models. But over time, we hope to make greater use of the benchmarking products that we're developing from our patient level costing data and other sources to make to drive a more sophisticated payment model that based on the efficient level of provider costs. And we're also looking to review the way that quality incentives work in the payment system. So thanks for listening, and I think I'm happy to take any of your questions.
Thank you so much, Martin. That was absolutely fascinating. Hi, my name is Kees van Goorlen. I'm one of the executive directors at IPA, and it's my pleasure to moderate the Q&A session with you this afternoon. Wish it wasn't a conference and I could just ask you questions for the next few hours, but okay, I'll be a good host and I'll recognize that there are other people in the room. So the questions have been coming in thick and fast. So let me start with the first one by Julia Hume. What if hospitals do not complete the activity that they planned? Is the budget recouped?
So if they don't deliver the it depends what type of activity we're talking about. So if they don't deliver the elective activity that they planned, then yes, the sum of a proportion of their budget will be recouped. So we'll recoup 75% of the value of the activity that's not delivered. We'll recoup that. But if they don't deliver the level of emergency activity or other activity that they don't deliver, then the hospitals can get to keep that. And I think that puts the incentives in the right place, that if they're able to manage demand for emergency care, then actually that will benefit the system over time. But really we're trying to put in place a payment system so that hospitals are just reimbursed for the level of elective activity that they undertake.
Great. Has the quantum of funding in the system changed between activity-based versus blended payments?
Not really, no. So it's essentially the same scope of activity. So the only difference would be that previously we had a set of national prices mainly for the majority of acute activity, so for elective, non-elective, outpatients, etc. And we had some fairly broad payment rules for activity outside the national rules. But what the blended payment model is, it sets out some rules for all activity within the payment scheme. So whether they had national prices or local prices, it sets out those payment arrangements for everything. So we move to a consistent payment system using the same sort of design for both acute mental health and community, because in the past we had very different payment models for those services.
A question from Michelle Evans. Does the quality or outcomes component have any relevance to value-based healthcare? Is this something the NHS is looking at?
It is, and I think it does have a relevance to that, whether people call it value-based healthcare or a sort of quality incentives. I think that's exactly part of what we're looking at in terms of how do we move to a sort of value-based payments or value-based commissioning. As I said, the quality incentives that we've got in the payment system at the moment are based on quite micro level clinical incentives. So that's one of the things we're looking at, whether we need to look to a broader measures of value or quality within the payment system and putting incentives into the payment system as part of that.
Right. Okay. And is that also where I suppose the models of care and the evidence on those models of care come into play?
Yes, that's right. So looking at the development of best practice pathways, for example, that's part of the sort of value-based payments. So with clinicians coming up with designs and costing those best practice pathways so they can be used as part to inform the fixed payment for hospitals. That's definitely the right approach. But actually, we found it quite tricky to get clinical consensus on the best practice pathways for even the simplest procedures. Actually, it's been quite surprising. You'd think a cataract, straightforward, blah blah blah, but actually it's pretty tricky to get the clinicians around the table to agree exactly what is, particularly with the use of more use of primary care and things like that. It's a bit tricky, but just those what you'd think were relatively repeatable high volume procedures, we should be able to get an agreed pathway and be able to cost that pathway and say this is the best practice, this is based on the best practice, these are the costs you should be looking. It's actually been really tricky to get agreement on that.
Question from David Dean, slightly on the other side of the quality aspect. The cost side question is, requires detailed tracking of nursing time, doctor time, surgical supply usage, etc. for specific patient episodes, rather than just dividing all the costs of the department by the number of patients treated that month. How sophisticated is the costing? Sorry, my question has disappeared, but I think I know. How sophisticated are the costing systems in England?
So I think we're improving, but I think we've come quite late to the sort of detailed costing information that we collect, and I think there's still a real variation between different hospitals in how sophisticated their costing systems and the data underpinning their costing systems are. We've got quite detailed guidance on how the costing information should be collected and calculated, and some hospitals are really using that information to support their day-to-day business, which is exactly what we'd be hoping to do. But some others are really sort of struggling with the quality of their data systems to support the costing data. But I think the structure and the framework is there, but we certainly haven't got a consistent level of the quality of costing data yet, because I said we've only had probably 2 or 3 years of collecting patient level costs from every acute hospital, and we've only had 1 year of collecting costs from mental health providers. Previously, we collected aggregate costs from hospitals, which again had various levels of quality of the data quality from within that data set.
Yeah. Question from Julia Conway: was the change in the payment system and the Act difficult to achieve? They appear to be quite substantial changes in a relatively short period of time.
Yeah, so
maybe it's not a short period of time in your eyes.
Yeah, no.
It's
quite interesting. So most of the proposals in this Act came about from a set of proposals that came from the NHS rather than came from politicians. So this was the sort of our NHS, particularly the RX chief executive Simon Stevens, who was saying, from the old 2012 Act, these are the issues that we've got with the current legislation that's making it difficult for us to implement the proposals in the NHS long-term plan. So actually, I'm not saying it didn't get consistent support across the political spectrum, but compared to previous legislation on healthcare, it's got through fairly smoothly. I mean, there was some elements that the politicians added to the legislation that were maybe a bit more controversial than others, but the ones around the introduction of integrated care boards, particularly, generally received fairly widespread support.
Great. Yeah. Okay. Very interesting. Last question, I think, for what we have time for. How do you measure the efficiency of service provision across the system? And I might ask a follow-up question, because there was also a question around, are you measuring quality in your benchmarking exercise?
Yeah. So that's a brilliant question, isn't it? How we measure efficiency across the health service. So previously our measure of efficiency was probably how many widgets are we producing for the pound, and which isn't a great measure in terms of what we're trying to do. So I haven't got an answer to this, but I recognize the problem, and I recognize we need to try and resolve that measure. How are we measuring efficiency? And as part of that, the other thing I would say is, rather than just looking at improvements in technical efficiency at hospitals, what we're also looking at is how we can make improvements in allocative efficiency, by sort of commissioners making the best use of the resources available to them. And hopefully that the move we've made from the episodic payment to a more bundled payment enables that, or supports that sort of looking at allocative efficiency savings rather than just technical efficiency. And the production of the benchmarking products that we're hoping to do will again hopefully support that. So I haven't got an answer in terms of how we measure it, but I know that we do need to look at both technical and allocative efficiency within what we're trying to achieve.
Terrific. Well, that wraps up this session. That's all we probably have time for, except to say that was absolutely fascinating, and loved every minute of it. And I hope you'll be able to rejoin us at some point and let us know how things are going, because I think you're also made it sound like you're in the middle. To me, it still looks like you're at the start of something really exciting, and lots more activity and evaluations to go.
Yeah, definitely. Yeah, and well, so thanks again for the invite, and I say more than happy to join in any further discussions with you and colleagues around both what we're doing and what developments you're doing in Australia. So that would be really helpful. So yeah, thanks for the invite, and thanks for listening.
We'll certainly take you up on that. Thank you so much.
Thank you.
Excellent. So thanks very much, Martin and Keys, and Martin, very much appreciated. So it's now time for people to jump out of this session, and then we'll be back momentarily for our first panel session, which is the international perspectives and applications of activity-based funding. Thanks very much, and I'll see you in a minute or two.